we were at our NIA gathering in DC, Mark said to the audience, "You're doing elder abuse research and you just don't know it." And that was wonderful because it was sort of breakthrough. And to your point, whether it's caregiving or whether you're looking at wound healing or whether you're looking at a person's capacity to be ambulatory, you have the opportunity to think through what's reasonable and what could potentially be mistreatment.
Welcome to the NCA's podcast, Conversations on Aging and Justice, your trusted source for the latest in news, research, and policy in elder justice. The NCEA is excited to introduce the OGs of Elder Justice series, where you'll hear trailblazers in the field share their passions, joys, collaborations, frustrations, and innovations, or any combination thereof, in elder justice through informal and candid conversations. In this installment of the OGs of Elder Justice, Dr. Terry Fulmer and Dr. Mark Lachs share their 35-year collaborative journey and impact in the elder justice field. Together, they've expanded the horizons of elder justice research and the diverse pipeline of elder justice experts through the National Collaboratory to Address Elder Mistreatment. Dr. Terry Fulmer is the president of the John A. Hartford Foundation in New York City, a foundation dedicated to improving the care of older adults. She's the principal voice for the Age-Friendly Health System Initiative and is nationally and internationally recognized as a leading expert in geriatrics and elder abuse and neglect. Dr. Mark Lachs is professor of medicine at the Weill Cornell Medical College and co-chief of geriatrics and palliative medicine and the director of geriatrics for the New York Presbyterian healthcare system. His major area of interest is underserved older adults. He has published widely in the areas of elder abuse and neglect, adult protective services, the measurement of functional status, ethics, and the financing of healthcare.
So, Terry, it's like a homecoming weekend here. We go back, and how great to see you. Let me start by asking you how you got started in elder justice.
Mark, it's always so much fun to work with you, and you've been a gift to me throughout these years where we've focused so keenly on elder justice. And so how I got started was I was a practicing nurse at the Beth Israel Hospital in Boston, and I saw older people who presented on the floor with signs and symptoms that were incompatible with any disease process I had ever learned. And I just knew that something was not right. That was 75. In 77, Massachusetts started passing its mandatory reporting laws. And by 82, we were underway. And I was a representative for the hospital and started the elder abuse team at the Beth Israel. So really starts in the clinical world for me. And it's been my passion ever since. And I'd ask you the same question.
Yeah, well, as you had a lot to do with it. Because fast forward a few years later, when we found ourselves at the same institution, Yale, me as a clinical scholar and you as a brand spanking new assistant professor of nursing, as I recall. So this would have been 88 or thereabouts, right? Three things happened. There were three sort of converging moons. You, it was clinical. I was supporting my student loan habit by working in the emergency department. And I saw a lady, I'll never forget it, who came in with cigarette burns on her chest. And those were the days of the physical medical record. And so you had to call downstairs and they bring this dusty thing up. And she had a record that went back into the 50s. New Haven has only 2 hospitals. And I went back and saw this woman's history. And for 30 or 40 years, there was domestic violence that was written off as sort of narcissism or histrionics or confabulation or depression. She had been coming with fractures and injuries. I just thought to myself, this is crazy. And here I was in a fellowship program, the Clinical Scholars Program, with a very famous mentor of both of us, Alvin Feinstein, where I was supposed to look at the intersection of societal problems with medicine. And it seemed to me to be directly in that wheelhouse. And then I meet you, who was studying elder abuse. And you pushed me, and I'm so grateful that you did. So let's talk a little bit about the areas of elder abuse that we've concentrated on. And it's changed, right? As we've not solved, but made headway with some of the problems. We started with risk factors, and now we find ourselves with kind of some evidence-based interventions, so talk a little bit about your early career. I know you were interested in neglect.
So the first screening, as you pointed out, that was really the entree at that time that I was responsible for was at the Beth Israel. And so we started in the emergency room. We created an elder abuse screening instrument because there wasn't any. So I was working with wonderful people like Ken Meinecker and Terry Weddle and Richard Besdine and Jack Rowe. And they were very supportive. Jack did warn me. He said, Terry, there's no funding for elder abuse. You're going to have a really hard time. And I heard him and I said, thank you. And I'm going to keep trying. Just like you just said, you have to work on something hard. So I worked on screening. And then as I transitioned to Yale, which was a wonderful place to work, I got a small grant from VOCA, Victims of Crime Act money in Connecticut, from a woman named Ida Arbitman. I will never forget that. And we were screening for elder abuse and neglect in the emergency room. And the data came back very clear that the most frequently checked off box was neglect. And that just compelled me to work on elder neglect as a form of elder mistreatment for the next many years. But you came to my rescue in that work because as I was screening, I wanted to work with her data set. You talk about that. Do you remember that?
Yeah, I mean, I was doing this intensely quantitative thing with Alvin Feinstein. And some of my first papers were with you. Yeah. The first risk factor papers was a collaboration from my data set. It is homecoming weekend, Terry.
It is. It really is a great memory lane, isn't it, Mark? And you knew SAS and I had no idea. And so I remember I was expecting my son because I was quite pregnant and we were walking up these dusty stairs to get boxes of materials from the Office for Aging so that we could match their cases on your perfect case match with the Yale, the EP study. And that was the first time we could say with some clarity that we were learning something.
Yeah, let's talk about that for a second because it's had impact beyond elder abuse. So we had the gratuitous experience of being in a state where there was this long epidemiologic study, this EPIS cohort funded by NIA, which began in 1982, in which they followed 2,812 people for 15 or 20 years, measuring every last thing about them: cognition, memory, medicines, hospitalizations. And fortuitously, the state of Connecticut in 1979, 3 years before the inception of the cohort, was one of the first states with mandatory reporting. And our brilliant idea, and it was brilliant, but was to essentially see if any of those cohort members were seen by adult protective services. And then it turned out that an extraordinary number were, I think it was 173. I think about 7% of the cohort, 7% of the older people in New Haven had been seen in protective services. And we identified important risk factors and became the sort of Framingham of elder abuse, right? Yeah. And then subsequently we did work on outcomes because we had death certificates and hospitalizations on these people. So merging this administrative data set of APS with the EPIS cohort was sort of revolutionary. Now I look at all these studies where the MDS is melded with Medicare data. I mean, data merging now has become all the rage. And this was one of the first studies really to make use of that. And it's probably those are some of the most quoted studies in elder abuse to this day.
And to be clear to the audience, that would never have happened without you. I knew what I was passionate about and that I needed those records, but I would never have matched on it. And thankfully, it captured your interest, Mark, because if it hadn't, we wouldn't have you in the field. And what an enormous loss it would be. You are the #1 investigator in elder mistreatment in the nation and probably in the world. And I consider it my great good fortune to have been able to capture your interest. No matter where you put your interest, it was going to be powerful and impactful. And I remember Al Weill saying to me, he was head of the emergency department. He said, Terry, I got a live one for you. I really think Mark is going to enjoy this work. And there it went. And so what a moment that was to say, I have this really smart person, this physician who's willing to work on this, and you've stuck with it. And that has been the greatest gift, really, to the field, is to have your interest on this.
Catching my interest is not enough. You were a mentor to me, Terry. You were a first early mentor. So, well, let's just move on. I'm turning red. You've had an extraordinary career in research and policy and in running a foundation in academics and being a dean of a nursing school. When you look back on it, What's the first thing you'd wish you had known?
It's interesting because the phrase elder justice is powerful. And I wish I'd known that language to get us moving in those days, because when you talked about elder abuse, people really didn't want to talk about it. They really did not want to talk about it. It was like, they're old. What do you expect? What are you going to do about it? These people are confused. They're demented. But I never knew enough to insert the word justice. I knew things were not right, but I didn't have that word. And I wish I had, because all of us can react in a meaningful way to justice. How about you?
When you tell a lay audience about elder abuse, they're horrified. And you say, well, you've got to remove this person, like surgically excise this person from an environment. And that happens about 0 times. And I've come to view elder abuse the way I view chronic disease. It's really about risk reduction. When I think about the chronic diseases I treat as an internist, asthma or COPD, the disease gets better and then there are exacerbations, but you can improve quality of life, right, without sort of a cure. And I'm an internist. I don't cure anything. My job as a geriatrician is to help people live in the face of inevitable diagnosis and chronic disease. And I think I was swinging for the fences, Terry, when in fact you have extraordinary impact on people just by getting them help.
It's interesting because I love that analogy. And I think it's a powerful analogy to say to people, this is yet another chronic problem. And you pointed that out in your opening case with a person who had had a record that went on and on and on. But following it, one of the things that the Beth Israel was willing to do for me in those early days was, we didn't have any such thing as an electronic health record. However, there was a guy who was in charge of the admitting office, and I asked him if he would put an EAT, elder abuse team, checkbox on anybody who came to the elder abuse team, so that if they came twice, we'd know it. And he did. He just did. And we didn't go through a protocol. We didn't ask the IRB. We didn't, just wasn't that way. And again, no electronic health records. To your point, what were some of the things that we've learned? And following this chronic problem is really important. And so, I think that you and I have both impacted the field in meaningful ways by saying the chorus was saying, what is a reasonable presentation for an older person? What are you missing? Because you are conflating the idea that someone has exacerbations of symptoms that really aren't consistent with their chronic disease or disorder.
Yeah. You said something about the guy in admitting, and that was a lesson you taught me. Terry's very good at getting people to do things for her in a non-manipulative way. I mean, showing goodwill. People want to be part of something pure. And how many creative things have we done by involving bank tellers, doormen, anybody who will, we've just gotten the radiologists here interested in getting involved in imaging of fractures and discerning what's abuse and what's not. And look, I mean, geriatrics is a team sport, but I think elder abuse is particularly interdisciplinary. You look at Laura's work, multidisciplinary teams. One of my big bête noires these days is trying to broaden the tent of what we consider elder abuse research, right? So if you're doing caregiving research, Sarah Saj is a magnificent member of my faculty, expert on caregiving, co-PI on the REACH study. Caregiving gone wrong can become elder abuse, and we need to support caregivers. Du Khan, my collaborator at USC, does neuroimaging. He's a neuropsychologist, and he's looking at the financial vulnerability of people, financial exploitation being a very common form of elder abuse. So he's a neuroscientist studying brain vulnerability to elder abuse. So there's so many things that we can call elder abuse to bring people into our tent. What do you think?
I love that. And when we were at our NIA gathering in DC, Mark said to the audience, you're doing elder abuse research and you just don't know it. And that was wonderful because it was sort of breakthrough. And to your point, whether it's caregiving or whether you're looking at wound healing or whether you're looking at a person's capacity to be ambulatory, you have the opportunity to think through what's reasonable and what could potentially be mistreatment. And so adding that factor, adding that aspect into any one of these wonderful NIH studies gives us even more data, but it also, as you said, Mark, draws people into the field. And I'm really, really proud of the Elder Mistreatment Collaboratory work that you and others have been so great in participating in. And thankfully, the John A. Hartford Foundation, where I work, was willing, the trustees were willing to fund that. The whole notion that we could get a new batch, new cohort of new investigators with us has been very, very exciting to me.
Well, first of all, thank you for the money.
It's the trustees, Mark. Yep.
Yep. And thank the trustees. I mean, sometimes, very occasionally, the right person gets the big job. And that's happened to you, Terry, when one of your dearest friends and 30, 40-year professional colleagues is given the keys to the candy store. I knew this was going to be good for elder abuse. And the collaboratory has been absolutely remarkable, but not just for the science and the service, but also for the relationships. And when I was pretty lonely, Terry, at the beginning, now there's a whole cadre of physicians and social scientists and nurses and people that feel like there will be a legacy for us who want to carry on the work. MT Connolly, we were in DC recently at a policy convening. MT used to say, we don't know what works. We don't know what works. And I sort of teased her a little bit. I said, kind of getting to know what works. Okay. You saw the RISE intervention, David Burns, the interview for decisional abilities we've created for adult protective service workers. We are starting to have an evidence base. I think we were lumping at first. All the elder abuse was put in the same sort of bucket of exploitation, physical abuse, sexual abuse, neglect. And there was a time when the field had no other choice. But now we're starting to look at this getting disaggregated. And of course, the risk factors for neglect are different than the risk factors for physical abuse or financial exploitation. And we're getting granular. We first, in the Framingham study, it was blood pressure and cholesterol and smoking and diabetes. And now we found a whole bunch of metabolic markers, right? And they come up with new ones every day. Fractionated lipids as, individual risk factors. And I see our work is sort of heading in that sort of analogous direction. The variables tend to be psychosocial, but this is hard science. I mean, this is not tree hugging. I think that
tree hugging.
So incredibly excited. What excites you about the future, Terry?
Oh, I think that to your point, that we do know actions to take. We have evidence base. You pointed out Dr. Sarah Saja and her incredible work, along with yours, Tony Rosen's. People across the country really doing some great work, and we're learning things from our colleagues internationally as well. So I love that there's this burgeoning group of experts who are committed and are building on one another's scientific base. So that's good. And thanks to the National Institute on Aging for their commitment to helping us with our ideas and with that rigorous peer review, getting over the fence. So I know that we're supposed to also talk about a key principle that guides us professionally and personally. And maybe you could start with that, Mark.
Well, it says one key principle, and I'm going to violate that because I have two key principles. OG's prerogative. The principles have changed over the course of my career. I mean, obviously, an overarching principle writ large is protecting the health, dignity, and quality of life of older people. I mean, they're a precious resource. And so that guides everything we do. But as I get older, there are two things that really matter most to me. One is mentorship, paying back what was done for me, what you did for me, what Alvin did for me, and just making sure there's a cadre of young people who are going to bring the field forward. And it's the funnest thing I do. Yeah. It's the funnest thing I do is get junior people sort of hyped up to do this work, and I'll help anybody, who's interested. And the second area is dissemination. I'm just sick of going to GSA and seeing hundreds of evidence-based studies that sit sort of fallow.
Yeah.
There's just not uptake. As scientists, we've been good at doing the research and then moving on to the next project, but not terribly good at getting it out into the world. The Collaboratory, by the way, is not going to do that. They're extraordinarily focused on dissemination. EDC has been crazy, sort of great, and taught me a ton about that. But I think we are past the point of just throwing an intervention up on the website and predicting people will sort of pick it up. What about you?
I love that. You have to roll up your sleeves, that's for sure.
Yep.
The key principle that has always guided me is the following. I am all about eradicating ageism. And is infused and embedded in all of my work. Ageism is something that we can eradicate in our lifetime. Ageism, that is prejudice against a person because of their age, treating them a different way because of their age, offering them treatments like surgery or not because of their age, and thinking that their symptoms are compatible because of their age instead of what's going on with them in a fully comprehensive way. So eradicating ageism is really, really important to me. And it's just an element to all my work. And finally, the last thing I'd say is relationships. And Mark, you're such a classic example of that for me. What we've done is we've built relationships, which has spawned what's going on and takes us to the Temkin Symposium and all those wonderful people who are now just absolutely committed.
Yeah, I'm going to ask one last question, and I think I know the answer, and because that's probably the same answer for me. So, Terry, what's next for you?
I'm working on a construct called creating age-friendly health systems. And an age-friendly health system, there's no such thing as an age-friendly health system that does not address and confront and change the trajectory of elder abuse and neglect.
When I said what's next for you, I meant career-wise.
Washington's not calling me, so I'm right where I want to be, Mark, and I love it. It's just so exciting.
Yeah. As I said earlier, I suspect it's the same answer that I have. I have no plans to go anywhere. I love what I do. I feel blessed. The only way to build a career in an environment like the ones we built really is one brick at a time. I have really no ambition beyond what I'm doing now because I love what I do. I suspected the same for you as well. And I need you in that position, Terry.
Right here.
I got to keep picking your pockets, for God's sakes, okay?
It's a wonderful thing, Mark. And the money spent with us together is money that is a good thing for older people.
Thank you for tuning in to this episode of the OGs of Elder Justice podcast series. If you've missed any of our previous episodes with amazing OGs like Dr. Laura Mosqueda, MT Connolly, Dr. Georgia Anitsberger, Erica Wood, Naomi Karp, and many others, please catch up on NCA's YouTube channel or Spotify.